Good morning. My name is Tamara Thompson. I am a student at Northern Kentucky University. I am presenting today on provider implicit bias and knowledge deficits in treatment of opiate use disorders. In January 2023, the government removed the requirement for the X waiver to expand access to care for patients suffering from opiate use disorder. Despite the removal of the X waiver requirement, medications for opiate use disorder continue to be underutilized. Research indicates that barriers include lack of education, personal bias, and stigma related to the treatment of OUD. The goal of this DMP project is to improve provider education and comfort levels in prescribing medications for opiate use disorder and to help them identify their own implicit bias related to the use of Suboxone in the treatment of OUD. The objective of this project is to improve provider knowledge and awareness of implicit biases in prescribing medications for opiate use disorder. The methodology will include pre- and post-survey model assessing biases and knowledge deficits, followed by an educational intervention. The PICO question will be stated as such. In board-certified advanced practice providers in Kentucky, how does education on implicit bias and medications for opiate use disorder compare to their knowledge and comfort levels before the education affect their level of knowledge and comfort in prescribing these medications over a period of 30 days? Okay, let's talk about some opioid statistics in Kentucky. In Kentucky, approximately 1,984 overdose deaths were reported in 2023. This represents 32.5 per 100,000 residents, which is 50% higher than the national average. The CDC estimates more than 1,000 emergency department visits daily secondary to opioid overdose, with 91 opioid overdose deaths per day. This project is clinically significant. The objective is to address underutilization of medications for opiate use disorder and to improve prescribing practices among APPs in Kentucky. The target is to enhance knowledge and comfort levels in APPs prescribing medications for opiate use disorder in Kentucky, and the expected outcomes would include better patient outcomes, reduced relapse rate, lower overdose mortality rate, and improvement in evidence-based treatment practices. As you can see, the overdose death rate continues to climb every year. This map serves as a visual representation of Kentucky overdose deaths involving fentanyl, retrieved from the Kentucky Injury Prevention Research Center. If you'll notice, there are very few counties in Kentucky that are not affected by overdose mortality from fentanyl. Implicit bias in healthcare can lead to reduced empathy, unequal treatment, and underprescribing of MAUD, often reinforced by stigmatizing language which may discourage patients from seeking or staying in treatment. Now let's discuss some of the common stigmas in OUD treatment: moral failures, socioeconomic and racial biases, and mental health stigma. Viewing OUD as a moral failing leads to judgmental attitudes and inadequate treatment. This perception reinforces stigma, resulting in less compassionate care and delayed or punitive approaches. Patients with lower socioeconomic or racial ethnic backgrounds face disparities in OUD treatment. Black patients and those with lower income are less likely to receive buprenorphine, reflecting systemic bias. Misconceptions about mental health and addiction contribute to fragmented care, where co-occurring disorders are inadequately addressed, leading to poorer outcomes. Stigmatizing language in healthcare. Everyday language often includes terms like addict or junkie, which perpetuate negative stereotypes and influence public and provider attitudes towards individuals with OUD. Terms such as non-compliant or drug seeking are commonly used by healthcare professionals and reflect underlying biases that can negatively impact patient care. Media and public discourse often sensationalize drug use, focusing on criminal aspects rather than the health crisis, thereby shaping societal attitudes and influencing policy decisions that are more punitive than supportive. Individuals with OUD often internalize negative stereotypes, leading to a self-stigma, which can be a significant barrier to seeking treatment and maintaining recovery. Okay, now let's discuss strategies for providers to mitigate implicit bias. Education and awareness. Engage in ongoing training to understand the nature of implicit biases and their impact on healthcare delivery. Such training can include using tools like the implicit association test to uncover subconscious biases. Educate yourself about the biological, psychological, and social factors contributing to OUD to better understand its complexity and reduce stigmatizing attitudes. Regularly reflect on your interactions with your patients to identify and address potential biases. Reflective practice can help healthcare providers recognize their own prejudices and take steps to mitigate their impact on patient care. Culturally competent care. Develop cultural competence to understand better and respect diverse backgrounds. Adapting treatment plans to be culturally sensitive and inclusive is essential in addressing the needs of all patients, particularly those with marginalized communities. Use non-judgmental supportive language when discussing OUD with patients. Encouraging open dialogue and active listening can help healthcare providers understand patient experiences and perspectives, leading to more effective and empathetic care. Involve patients in the decision-making process about their treatment plans. Respecting patients' autonomy and preferences in their care is critical in building trust and improving treatment adherence. Provide patients with access to support groups, counseling, and other resources to assist in their recovery journey. Ensuring continuity of care by coordinating with other healthcare providers and support services is essential for successful long-term outcomes. Now I'd like to introduce you to ASOM's Principles of Harm Reduction. The American Society of Addiction Medicine advocates for harm reduction strategies to minimize negative health outcomes associated with opiate use. Key strategies include providing access to MAUD, promoting safe injection practices, and supporting supervised consumption sites. Okay, so how do you define opiate use disorder? The criteria overview for the DSM-5 outlines 11 criteria for diagnosing opiate use disorder, categorized into impaired control, social impairment, risky use, and pharmacological criteria over a 12-month period. Severity levels are determined by the number of criteria met, with mild being 2 to 3, moderate 4 to 5, and severe considered 6 or more. Clinical indications to initiate MAUD include moderate to severe opiate use disorder. COWS scoring combines subjective and objective clinical findings and cannot be performed on a sleeping person. I think this is important to remember because often I'll have nurses come to me in the hospital and say, well, he can't be in that much withdrawal because he's asleep. And I think it's really important to remember that sleeping is a coping mechanism, and that if you want to do an accurate CAL score, you have to have participation from the client. Scoring criteria ranges from 0 to 36 based on symptoms such as pulse, sweating, restlessness, and GI distress. CAL scoring should be reassessed at each visit to individualize dose adjustments per patient needs. Now let's talk briefly about how Suboxone prevents opioid overdose. Naloxone is not the active component preventing opioid overdose in Suboxone. Instead, buprenorphine binds to opioid receptors, blocking illicit drugs from binding. Buprenorphine is a partial mu-opioid receptor agonist, reducing withdrawal symptoms without causing full opioid effects. Doses above 24 milligrams do not increase respiratory or cardiovascular effects, thus reducing overdose risk, and this is known as the ceiling effect. Naloxone deters misuse by causing withdrawal if injected by opioid-dependent individuals. Buprenorphine has a very long half-life, 24 to 42 hours, and this minimizes fluctuation in opioid levels and thereby keeping patients out of withdrawal. Therapeutic doses of Suboxone provide stabilization without euphoria, avoiding the highs and lows seen with full agonist opioids. This is by far the most important slide of this presentation, and it talks about the efficacy of buprenorphine. When you put a patient on 2 to 4 milligrams of buprenorphine, that covers 50 to 60% of their opiate receptor sites. If you increase that to moderate dosing, which is 8 to 12 milligrams, this covers 70 to 85% of opiate receptor sites. And if you put patients on what is considered to be the gold standard dose of 16 milligrams or above, this covers 85 to 95% of receptor sites. Now, I know there's always concern about patients abusing Suboxone, but you need to remember that Suboxone has a ceiling effect. Doses over 24 milligrams are doing nothing extra for the patient, and they are at no greater risk of overdosing because they are on a dose of 24 milligrams. And you have to provide patient-specific care. If you have a patient that is coming off of doing 2 grams of fentanyl a day, they may need that 24 milligram dose, which can eventually be tapered down. But you can't just cookie cutter treatment. It doesn't work. You have to go based on the needs of your patients. And it is important to remember that if they have Suboxone on board, that significantly decreases their chances of an opioid overdose. So let's talk for a second about initiating MALD. You will need to conduct a comprehensive assessment, including medical, psychiatric history, substance use, and family psychosocial supports. You will want to check a CASPER or a PDMP, review prescription history to detect unreported medication use. You will want to know if they are on anything that can cause increased respiratory depression, like clonazepam, Xanax, any kind of benzodiazepines are contraindicated with use of Suboxone unless they are being monitored by an addictionologist or a psych NP. You'll want to focus on addiction-related findings, including physical exam, lab testing for opioids, and other drug screenings. I think it's important to remember when you're doing that baseline drug screen that that is not punitive. That is not going to prevent you from prescribing the medication if they are using methamphetamine or other substances. That is to get an idea of where patients are and how you can better help them. And then you'll want to talk to the patient, explain the medication, and do informed consent. Explain medication function, risk benefits, discuss overdose prevention. I always discuss the fact that Suboxone has a very long half-life, and when you stop that, that withdrawal from that medication, if not tapered down correctly, can be worse than withdrawing from fentanyl, and it can last much longer. And I think patients need to know that going into treatment. So let's talk about initiation of Suboxone. First, you'll want to ensure that the patient has been abstinent from short-acting opioids for at least 12 to 24 hours and is in mild to moderate withdrawal. Start with a low dose, beginning with initial dose of 2 to 4 milligrams of Suboxone. Reassess the patient every 1 to 2 hours and administer additional doses as needed to control withdrawal symptoms. So in the office setting, if a patient is Suboxone naive, that means we do the induction in the office so that we can monitor their response. You'll want to monitor and adjust dosage, monitor the patient for signs of precipitated withdrawal or oversedation, adjust the dose based on clinical response, typically not exceeding 8 milligrams on the first day. Provide education, educate the patient on how to take Suboxone, including letting the tablet or film dissolve under the tongue and avoiding eating or drinking during this time. And you'll want to schedule a follow-up, arranging for follow-up within 1 to 3 days to adjust the dosage and provide ongoing support and monitoring. It is possible to prescribe Suboxone without stopping the use of their illicit drugs by microinduction. So that involves gradual dose escalation, starting with very small doses of Suboxone or Belbuca, half a milligram to 1 milligram, and increasing the dose incrementally over several days while continuing the use of full agonist opioids to prevent withdrawal. Minimize withdrawal risk. This method helps avoid precipitated withdrawal, making it suitable for patients on long-acting opioids or those with high opioid tolerance. As overlapping therapy, continue the patient's full agonist opioid as at a reduced dose during the induction phase, tapering it off as the buprenorphine dose is increased. And monitor the patient closely for signs of withdrawal or adverse reactions, adjusting the dose based on clinical response. Educate and support, provide thorough education on the process, and ensure robust support during the induction period to improve adherence and outcomes. To be honest, most of the time I did microinductions in the inpatient setting. However, I have done this in the outpatient setting, and it just requires much more frequent visits and monitoring while the patient is undergoing the induction phase. Okay, so how do we treat precipitated withdrawal if it occurs? Supportive care, provide reassurance and support to the patient, explain that symptoms are temporary and related to the induction of buprenorphine. Symptom management, administer medications to manage specific symptoms such as clonidine for anxiety and restlessness, antiemetics for nausea, and NSAIDs for pain. Buprenorphine adjustment, consider increasing the dose of buprenorphine if the patient can tolerate it, as higher doses outcompete the full agonist and alleviate withdrawal. I tell patients this all the time. If Suboxone puts you into precipitated withdrawal, it will also bring you out of precipitated withdrawal, and that is how you treat precipitated withdrawal, through the use of Suboxone. You will want to avoid benzodiazepines. Avoid using benzodiazepines due to the risk of respiratory depression and potential for abuse, and just monitor the patient very closely for improvement and any adverse reactions, adjusting the treatment plan as necessary. Okay, so other treatment considerations. You must make sure that you prescribe naloxone, co-prescribing naloxone for overdose reversal in case of accidental overdose, especially if the patient is using other CNS suppressants. Educate patients and their families on how to use naloxone and recognize the signs of an opioid overdose. Regularly monitor patients for adherence to the treatment plan, side effects, and any signs of misuse or diversion. Advise patients on safe storage of medications to prevent accidental ingestion by children or others. And incorporate a multidisciplinary approach to address the medical, psychological, and social needs of the patient. Studies have shown that use of Suboxone significantly reduces the risk of fatal opioid overdoses by maintaining patients in stable state and preventing withdrawal. Patients on long-term Suboxone therapy have lower mortality rates compared to those who are not on medication-assisted treatment. Suboxone increases retention in treatment programs, which is associated with better overall health outcomes and reduced mortality. When combined with psychosocial support and regular monitoring, Suboxone treatment leads to a holistic improvement in patient well-being and survival rates. Okay, so in summary, let's talk about the importance of offering MAUD. Expanding Suboxone treatment beyond opioid treatment centers increases patient access, particularly in areas with limited specialized treatment facilities. Primary care providers can offer holistic, integrated care that addresses both opioid use disorder and other health conditions simultaneously. Offering Suboxone in primary care settings can reduce the stigma associated with visiting specialized opioid treatment centers, encouraging more patients to seek help. Patients receiving Suboxone treatment in primary care settings have shown improved retention rates and health outcomes compared to those referred to specialized centers. Primary care providers can ensure continuous monitoring and support, enhancing the effectiveness of treatment and preventing relapse. Thank you for taking the time to listen to my presentation, and I'd like to introduce you to my little buddy, David Parks. David was my brother's best friend growing up from birth. The child spent his entire childhood at my house, and he terrorized me just as much as my brother did. And this is in remembrance of him. David died of an opioid overdose January 24th, 2016. I encourage you to remember when you are treating patients with opiate use disorder that at times it can be frustrating, but it is rewarding because you are helping someone's child, someone's brother, someone's mother, someone's everything. And I encourage you to remember that when you're interacting with your patients.